Thank you, Dr. Chow.
Okay, thank you, Cindy, for that kind introduction. Okay, and thank you for having me here today to talk about one of my favorite hematologic disorders, PNH. Okay, so this is the agenda for the next kind of 45 minutes, and hopefully I'll have some time for questions. So first, we'll start by talking about what is PNH in general. I was asked to highlight some of the new treatments that we have for PNH. The field has really exploded in the past few years, and so I'll talk about that, some kind of new exciting things that have just been approved and up and coming. And then I'll talk a little bit more generally about PNH treatment, long-term follow-up, and complications. Okay, so first of all, what is PNH? And so PNH, unlike MDS or aplastic anemia, where, that you guys have just heard about, where there are a number of different mutations and disorders, there's actually only one defect in PNH. PNH stands for paroxysmal nocturnal hemoglobinuria, but it's actually kind of a misnomer. It's a chronic condition with episodic exacerbations, and it doesn't really just happen at nighttime. So we kind of got the name wrong when it was named initially. Like I said, it's a stem cell defect. The mutation is in a single gene, the PIG-A gene, and this encodes a protein that's responsible for attaching, linking protein particles onto red blood cells. It's an acquired mutation, so it's not something you inherit from your parents. It's a mutation that happens after birth. And it affects all stem cells all cells that come from that particular stem cells, not just the red blood cells. But the red blood cells are the ones that are important in some of the pathology that I'll be kind of talking about. So these things that the PIG-A gene and protein is responsible to attaching to red blood cells are called CD55 and CD59. They deactivate complement. It's a rare disorder. It's an incidence about 1 to 3 per million per year. So what is complement? So complement, you may or may not remember from high school biology, is a host immune defense system. And it's a chain reaction of events. There are kind of 3 different pathways to activate the complement system, but they essentially all kind of converge on C3. All the complement proteins are named C proteins for complement. And so what's happening here is, let's see if I can point that out. I don't know if you can see that. So what's happening here is C3 splits off into C3A and C3B. C3B activates C5. C5 splits up into C5A and C5B. So it's kind of like a domino effect. And when you get down to C5B, this kind of sticks together with all of the C6s through C9, and that forms your membrane attack complex. The membrane attack complex, the idea is to actually fight infections. And so it can attack cellular membranes and it can blow up cells. The idea is to blow up bacteria that are invading your body. That's kind of their function. But this kind of system is kind of ongoing in the background at all times. Your own body's cells have a way to protect themselves from this kind of effect. And that's kind of shown here. We have these 2 natural inhibitors of the complement system, CD55 and 59. And these are the exact ones that your PNH cells are missing. So here's another graphic showing it on the cell surface. So at the top, you have a normal red blood cell. There we go, with CD55 and 59 attached to it. And at the bottom, you have a naked PNH red cell with no CD55 and 59. Complement happens in the background. In the normal case, even though there are some complement proteins depositing on there, you don't get the membrane attack complex because these inhibitors kind of make these complexes all fall away. Whereas if the naked unprotected PNH cell, you get membrane attack complexes and your cells essentially blow up. That is a process called hemolysis. Hemolysis is the breakdown of red blood cells and the release of these cellular contents. What's inside your red blood cells? You have your hemoglobin, which is necessary for carrying oxygen around in your body. You have iron, which is part of your hemoglobin, and you have all sorts of enzymes and things that really shouldn't be in your blood vessels. They should be in your cells. And so when you go in, you have some blood testing done to see whether you have hemolysis. These are the things that you see in the lab. You have a low hemoglobin or anemia. You have low iron. You have a high LDH, it's released from the red blood cells. You have a high bilirubin, also released from your red blood cells. And your hemoglobin is kind of converted to bilirubin in the blood. And then you have your body trying to compensate. It's ramping up your reticulocytes. Those are your young red blood cells in the bone marrow. And with all of this happening in your system, you have a lot of inflammation and you have a risk of thrombosis because you're really activating the platelet system. You're activating that whole inflammatory cascade. So to make a diagnosis of PNH, it's, compared to MDS and aplastic anemia, it's relatively straightforward. It's a blood test. And you basically just look for the missing GPI anchor that your PNH cells don't have. This is sort of a schematic of a flow cytometer. So you have your cell sample, and you label it with antibodies. You kind of have antibodies that stick to the linker protein, and then you run it through a cytometer and you see how many cells are missing the protein. So pretty straightforward. The cells that are missing that flare anchor, those are your PNH cells. And when you talk about a PNH clone or a PNH clone size, that's what it's referring to. The size, the percentage that is has that missing linker is your PNH clone size. You can do this process on all different kinds of cells, red cells, white cells, different kinds of white blood cells. You actually want to look at the white blood cells to have an idea of how large your PNH clone is, because the red cells in your body are actually actively being destroyed. So a lot of them aren't there to be measured. Typically, large clones are associated with what we call classic PNH, which is mainly what I'll be talking about. And small clones are associated with aplastic anemia and MDS. So I kind of show that on this slide here. And, looking at it, most patients either fall on one end of the spectrum or the other. There's kind of this in-between area where you have much fewer patients. So usually you can cluster people on one end or the other. So like I mentioned, patients that have a small PNH clone, anywhere between 0.01 to 10%, kind of on this side, this tends to be the group that is associated with aplastic anemia and MDS. And so patients that have those disorders, when you do the peripheral blood test, you can often pick up a small clone. Classical PNH, which is what I'll be talking about, where this hemolysis really becomes a big problem, is when you actually have a very large clone. So certainly there are patients that have clones up in the high 90s, where the majority of your stem cells are actually PNH cells. They're missing this kind of protective mechanism. There is a little bit of overlap, as you can see, the red kind of overlaps with the blue. So if somewhere you're between like 30 and 70%, it can be a little bit unclear. And you can certainly have, one disorder turn into have both disorders at different points in your treatment journey as well. I just have this slide on PNH and bone marrow failure. You've heard a bit about bone marrow failure already from my colleagues. Nearly 50% in some studies of aplastic anemia patients have small PNH clones. Not the ones that are inherited, but generally the ones that are acquired. It's also common in some myelodysplastic syndromes. Again, not all of them, but some of them. And mostly it's common in the ones where we think there's an immune component to both of these disorders. The thought is that, as you've heard from Dr. Kennedy, the T cells are the ones that are attacking the bone marrow in aplastic anemia and some forms of MDS. The theory is that the PNH cells are somehow protected from this immune attack. Maybe it's because they're missing the anchor, maybe it's because something else with the stem cells, but the immune system doesn't see them the same way. It doesn't attack them the same way, and so they survive. And if that process is ongoing, it creates an environment where this PNH clone can grow in size. Um, so, it's probably not the complete picture because classic PNH, where you have very large PNH clones, some of them don't come to you with a history of bone marrow failure. If you look closely, sometimes you can sort of say, detect, perhaps there was some subclinical bone marrow failure, perhaps there was something that happened maybe like a few months ago or around the time, but often it's not completely clear. So that's the theory, but we don't have maybe kind of all of the pieces there. All right. So the rest of this talk will really focus on classic PNH. So classic PNH is also referred to as hemolytic PNH because that's kind of the main presenting problem. And so, like I mentioned, classic hemolytic PNH, classically you have a very large PNH clones. The symptoms are varied and multi-system. And so almost all patients present with anemia and fatigue just because of the way this works. The cells are falling apart, and so they all have anemia. And then there's a variation in sort of like how much people have these other symptoms. But if you look at kind of going down the list of symptoms, it's a high percentage in many different organ systems. And so people can come to doctors and complain about abdominal pain or erectile dysfunction. A lot of people complain about fatigue or shortness of breath. There's a significant proportion of patients that present with a blood clot, up to 30 to 40%. And sometimes those blood clots can be in usual places like your lungs or your legs, and some of them can be very unusual blood clots, such as in your liver or even in your brain. Historically, because this was a rare disease, many doctors didn't think about it. And, early studies showed that it would sometimes take 5 years or longer from the first time somebody came to a doctor with a complaint to actually being diagnosed. I think this is improving. There's a lot more awareness of about PNH nowadays, and there are also sort of new exciting therapies as well. So people are thinking about it more often, and hopefully those stats are improving. So, quick mention about thrombosis, and really just because thrombosis in PNH tends to be the thing that leads to the most, we say the most morbidity. It tends to lead to the most complications and the most things that sort of affect patients' lives long term. Like I said, it occurs in 30 to 45% of patients. The mechanism is because the platelets get activated. So platelets are responsible for coagulation. They sort of stop bleeding. In PNH, what happens is that they get activated by this complement that's sort of going on in the background and all of the inflammation that's happening. This is kind of the thing we're always worried the most about in PNH because the first blood clot can be quite severe. Risk factors for having a severe blood clot in PNH are if you have a large clone size, if you have a very high LDH, a lot of hemolysis going on, if you have a lot of symptoms, like a lot of abdominal pain, a lot of shortness of breath, if you've had a previous clot, that kind of indicates that you're at high risk for further clots. And the thing about thrombosis in PNH is that being on a blood thinner alone is actually not enough to stop future blood clots because you still have that inflammation going on in the background. This is a guideline put out by the Canadian PNH Network, kind of to alert physicians and other healthcare workers about when to think about PNH, and it's called the CATCH criteria. The first two refer to things that are associated with PNH, so cytopenias that are unexplained, and A for aplastic anemia. And then the last three refer to symptoms. And so the T is for thrombosis, blood clots. The C is for Coombs negative hemolytic anemia, which is to say that it's a non-antibody mediated hemolysis. And the H is for hemoglobinuria, which is the H in PNH. So talking about PNH treatment. So I'm going to first talk about complement inhibition, which is kind of the first line therapy we think of as being as for PNH. And then we'll talk about possible treatment complications from some of these therapies, PNH complications, and kind of long-term follow-up. Okay, so complement inhibitors. So Complement inhibitors, they basically reduce or stop the flow of the complement cascade. You're kind of halting that domino effect. And so what happens is that you don't get the intravascular hemolysis. You're preventing those red blood cells from having holes punched in them by preventing that whole system from forming in the first place. Doing this essentially knocks out part of your immune system. So you do have to be very careful about monitoring for infections and being vaccinated for those specific kinds of infections that the complement system is designed to protect you from. Inhibiting complement doesn't fix the underlying stem cell defect. You've done nothing actually to fix the stem cell. You've actually just blocked it downstream, but you've not fixed the underlying problem. And so generally speaking, when we start on complement therapy, treatment can be lifelong. We expect people to stay on the therapy at least until it doesn't work anymore. Not everybody with PNH, with a PNH clone, needs treatment. So there's a lot of people I mentioned in the bone marrow failure, aplastic anemia group that have small PNH clones where this isn't really a problem. You know, it's a tiny clone. It's like less than 1% of your cells. It's kind of like, you know, who cares? So you have to have a minimum clone size of at least 10% to qualify for some of these medication therapies. And you have to prove that these red cells are actually a problem. The LDH is high. You're actually hemolyzing the red blood cells. And then you also have to have some sort of symptom, whether it's a blood clot, whether it's shortness of breath, whether it's severe abdominal pain. You kind of have to prove it to qualify for treatment. There are quite a number of drugs for PNH now on the market relative to what we had even 10 years ago. And so we'll talk about some of the established therapies, eculizumab and ravulizumab, which were the first therapies that were developed. New on the block is crovalimab that just got approved and funded. Then we'll talk about some of the proximal inhibitors, C3 inhibitor pegcetacoplan, and factor B and D inhibitors, iptacopan and danicopan. So here is a schematic of the complement cascade that I'm going to come back to several times during the drug talk. So again, I'll just point out how it works here. So we have 3 different ways of activating complement. They all converge on C3 convertase. C3 using factor B and factor D. C3 convertase uses factor B and factor D to convert C3 to C3b. And then C3b activate is C5 convertase. That converts C5 to C5b, and that results in your membrane attack complex when it's all assembled. The terminal complement inhibitors, eculizumab and ravulizumab, which I'll talk about initially, block the cascade here. So you're preventing this step from happening, and you don't get this membrane attack complex, and you don't get this. The proximal inhibitors work a bit further up the pathway, and they block up here. There's several different targets of the cofactors or the C3 itself. Okay, so C5 inhibitors. So eculizumab was the very first drug that was developed for PNH. And this paper is now old. It's from 2006. So this was a double-blind randomized phase 3 trial, which is kind of our gold standard as far as clinical trials go. And there were 87 patients, which was a lot for PNH patients that were randomized to either placebo or eculizumab. And eculizumab is an IV infusion. It's given every 2 weeks. And they looked at whether or not people's hemoglobin stabilized, and they looked at markers for intravascular hemolysis, specifically the LDH. They also looked at patient quality of life. They had them, answer questionnaires about their fatigue and their day-to-day life, and they kind of compared them throughout the course of the treatment. So this here is I'm going to show a bunch of these graphs, and they're all kind of set up the same way. And so on the y-axis, you have something that you're measuring, and here it's the LDH, so the absolute LDH level. And then here is time. And these are the placebo group in black and the eculizumab group in white. And you can see this is normal. This is the upper limit of normal for LDH. And the PNH patients are way up here when it comes to how high the LDH is. And so this is screening. They start on treatment at time 0, and you can see that the placebo group, it all kind of stays the same. Whereas for the eculizumab group, the LDH drops dramatically within 2 weeks of starting therapy, and it stays low throughout. Um, this is transfusion independence. And so on the graph over here, you have, again, the eculizumab group in black and the placebo group in red. And you start off with everybody up here. And every time somebody gets a transfusion, you kind of go down a little bit. You can see that the placebo group falls down almost immediately, whereas the eculizumab group, you need a few transfusions, but it's not nearly as much. This is the same thing in a table format. And so before treatment, you can see that they got roughly the same number of transfusions per year, like 8 to 9 transfusions per year. Whereas during treatment, those 2 years of treatment, the placebo group still got about 10 transfusions per year, and average for the eculizumab group was 0 transfusions. So very, very effective. This is the quality of life score. So there's a few validated scores that people use to sort of measure how people, how patients feel about this treatment in terms of their day-to-day lives. And the this particular a quality of life score is a validated fatigue score of 30 different questions in various different domains. And so everybody starts like this is baseline, and then you can see that the scores improve, like people got less fatigued in the eculizumab group, whereas with the placebo, it kind of stayed the same for a while, and then it started to trend down a bit. On the table here, you can sort of see how people felt their social, cognitive, physical, emotional functioning was on placebo or eculizumab, and same thing for symptom scales, fatigue, pain, nausea, vomiting. And almost everything got better with the eculizumab treatment. So it really was very effective for PNH patients that, previous to that didn't really have any effective therapies, where transfusion was kind of the standard. So in 2019, 13 years later, ravulizumab was developed. And ravulizumab is essentially long-lasting eculizumab. So instead of an IV infusion every 2 weeks, you get an IV infusion every 8 weeks, or even up to every 12 weeks on the study. There were 2 different studies. They were named 301 and 302. The 301 study looked at starting a ravulizumab, like randomizing patients to either ravulizumab or eculizumab. And the 302 study looked at patients that were already on eculizumab, had PNH established for at least 6 months, and then switching them either to, randomizing them either to switching to ravulizumab or staying on the eculizumab. These are forest plots, and the way you read them is that you sort of have a result, and you look at where it lands. On one side, this favors eculizumab. On the other side, this favors the ravulizumab. The point of these studies was actually to show that the ravulizumab was not worse than the eculizumab, that they were basically equivalent, and that is kind of what they show. And so if something kind of crosses the midline, the whole bar crosses the midline, it means it strongly favors that drug, that side, and it's statistically significant. None of those really do that. In these forest plots, you can sort of see that for most measures, transfusion avoidance, LDH, change in fatigue scores, everything kind of is a little bit further to the right, which favors ravulizumab. So there's a trend there, but it's not considered statistically significant. Okay. So from a practical standpoint, how these are given are IV infusions. And like I said, eculizumab every 2 weeks and ravulizumab now every 8 weeks. Typically, it's given at an infusion center close to home. There's a very robust patient support program that sort of organizes for you to have your infusion at a center that's closer to you than the hospital, Sunnybrook, or wherever you may be going for your medical follow-up. And in some cases, you can actually send an infusion nurse to your house to provide the medication. So that's quite nice too for our patients. Usually it's very well tolerated. Headaches are common when somebody is first starting. So like the first 2 or 3 infusions, people will get a headache afterwards. It has to do with how all of that inflammation is being shut down and how that sort of feels in like in your head to cause a headache. But after things are stable, usually people don't have side effects. Okay. So now, so that's what we had for a long time. This is a new one. This is crovalimab, and so it's a subcutaneous C5 inhibitor. And it just got approved, and funding came through for Ontario yesterday, and so it's relatively new. It's a subcutaneous injection that's given every 4 weeks, and you can do it yourself at home. So there were 2 studies, the Commodore 1 and the Commodore 2 study. And this is kind of a similar idea. So Commodore 1, it was the switch study. They basically randomized people that were on eculizumab to either stay on or to switch to crovalimab. And the Commodore 2 study was a sort of a new diagnosis study where somebody was newly diagnosed, hadn't started on anything, and they randomized them to either eculizumab or crovalimab. It's a little bit funny. They measured the proportion of patients with an LDH less than 1.5 times the upper limit of normal. So the proportion of patients that had an LDH indicative of a good response, if that makes sense. And so the crovalimab is in blue and the eculizumab is in red. The main point of these graphs is to show that the drugs are the same, like to show that they're comparable. So, oops. That wasn't supposed to happen. There we go. Okay, so again, the Commodore 1 study on this side, where patients were randomized to either stay on their eculizumab or to switch to crovalimab, you can sort of see that the LDH kind of stayed the same throughout their treatment, maybe a little bit different at the very end here. And then the Commodore 2 study, where you started off with somebody who had not yet been treated, you randomized them to crovalimab or eculizumab, and you saw that the LDH, the proportion LDH here kind of fell down to less than 1.5 times the upper limit of normal and stayed down. This graph is similar to this graph over here. And so basically, this study established that they were equivalent in terms of efficacy, measuring hemolysis parameters. You have the same forest plot over here showing that basically they're equivalent. I do want to draw your attention to two different things here. One is the fatigue score. So again, this is similar to the one that I showed for the eculizumab, where they showed that the absolute fatigue score got better after starting on therapy. So this is baseline and it's sort of both going up. Over here, this is a little bit blurry, but I think hopefully you can see. They asked patients which drug they preferred for patients who switched from one to the other. And 84% of patients preferred the crovalimab, 11% preferred the eculizumab, and 5% really didn't have a preference. And the reasons that they said they preferred the crovalimab were, one, the way the treatment was given was easier, so subcutaneous injection into the belly instead of intravenous into the vein. Number 2, fewer hospital visits associated with the treatment. And 3, the time to give the treatment was shorter. So an injection is minutes, an infusion is about an hour, or maybe a bit longer, depending on sort of where you're at and which sort of how well you tolerate the infusion. I will say that I personally don't have a lot of experience with this yet, as it just got approved, so I don't have any patients on it yet. But the trial experience seemed very good, and I think this will be an option that patients will be interested in. Okay, so I think we just talked about this, but the crovalimab itself, so it's an antibody as well, and it's made with this new technology called sequential monoclonal antibody recycling technology, and so you inject it into yourself, and it sticks around for a long time, like much longer than the eculizumab or even the ravulizumab antibodies. sorry, just the eculizumab one. So the first infusion actually is still IV, but then all the ones that you give after that are subcutaneous, so you give them to yourself. It comes in vials, and a dose is either 1 to 3 vials. You just draw it up and you administer it yourself. Okay. So that's all I had for that. Those were the C5 inhibitors. And those are all the ones kind of down here that we discussed. And next I'll talk about the proximal inhibitors. But before I do that, I want to talk a little bit about extravascular hemolysis. And so extravascular hemolysis is up here, and this is a section that I ignored when we looked at this slide previously. And so what happens is that when you have a blockage down here in the complement cascade with one of these drugs, you prevent this, but it also results in a lot of buildup up here, because this process is still happening in the background. You're just not allowing it to complete. And so you end up with a fair amount of C3 products that have been broken down. And what they do is they actually stick to your red blood cells anyways. And so, they're kind of floating around in your system, and they stick to these red blood cells in a process called opsonization. And these red blood cells are kind of tagged this way for your body to recycle. Now, you recycle red cells anyways. You're constantly making red cells and recycling them because they only live 120 days in your system. But once they're tagged this way, it sort of tells the spleen and the liver that they can be eaten up. They're old red cells now. And this is essentially called extravascular hemolysis. So it's hemolysis that's still happening. You're still breaking down red blood cells, but it's just not happening in your veins. It's your spleen and your liver eating those up. And with extravascular hemolysis, you get anemia the same way you do with intravascular hemolysis. You still get your own reticulocytes trying to ramp up and replace those red blood cells that are dying. You retain all of that iron, though. You don't lose it. So that gets stuck in your liver and your spleen in your system. And this is a kind of an on-treatment problem, because if we don't have kind of this blockage or this dam here, we don't really get that much extravascular hemolysis here. And so so then we had the development of these proximal inhibitors to sort of block this pathway here to get rid of this extravascular hemolysis problem. Okay. So the first one I'll talk about is the C3 inhibitor, pegcetacoplan, or Empaveli. Generally, I think of this as a second-line treatment. Usually we use it after the response to C5 inhibitor has not been adequate, like they're still getting hemolysis in spite of being on an inhibitor. Or they're getting a lot of extravascular hemolysis, really to the point where they're even needing transfusions for that extravascular process. Or if they're still having breakthrough. So in some patients, which I'll talk about later, some patients on therapy will still have hemolysis at episodic intervals. Not as bad as if they were not treated, but they will still have some of it. So there are 2 studies that I'll talk about, the PRINCE and the PEGASUS studies. Pegcetacoplan is administered again by yourself. It's a subcutaneous infusion, though it's not an injection, so it takes a while to get into the tissue. I believe in Canada we have this injector here, and so what happens is that you drop the drug in this syringe and you put it in this cassette, and then there's like a syringe pusher which occurs over a period of time, I think 20 or 30 minutes. You close the whole apparatus and then you attach the end of it to a little needle that gets stuck in your abdomen or wherever you're doing the infusion. You can either, I think there's a pouch you can wear, you can walk around with it. It takes about 20 or 30 minutes. You do that at home twice a week. This auto injector is a sort of a different delivery system. I don't believe we have this in Canada at the moment. I don't know if it's coming soon. Perhaps we can ask somebody about that. But it looks, it's a slightly different apparatus where you put the drug into the auto injector and then you just attach it to your abdomen and it infuses itself. Okay, so 2 studies looking at that. So The PRINCE study is a randomized phase 3 multi-center open label, and it was pegcetacoplan randomized to supportive care only. It was carried out in jurisdictions where the C5 inhibitors were not improved or people just didn't have access to them. So it really was kind of, supportive care was the standard of care in this particular study. So we'll just show these graphs, which you've seen now a few times. And so pegcetacoplan is in red and control is in blue. This is hemoglobin. And so you can see the hemoglobin improve once you're started on pegcetacoplan and not improve if you're on placebo. And you can see the LDH go down dramatically if you're on drug versus it not going down at all if you're on placebo. Okay, so that's fairly straightforward, I think. The Pegasus study looked at patients that were on eculizumab, and they looked at patients that were on eculizumab that still had anemia. So you were on a therapy, but it wasn't working as well as we were hoping, or it had stopped working. And they were randomized 2-to-1 for going on to going on to pegcetacoplan versus just continuing with eculizumab. And then I think afterwards you could switch. So they did a 4-week run-in where patients were on both therapies, and then they were randomized, and you either continued with pegcetacoplan or you just continued with the eculizumab. And you can see that the pegcetacoplan at the top, you kind of maintain a higher hemoglobin, whereas with eculizumab, it kind of fell down again. And again, these are patients that, had been on therapy for a while and still had kind of lower hemoglobins. Okay, so we talked about this a little bit already. So like I said, it's twice weekly sub-Q infusion. You get the drug delivered to your house, you store it in the fridge, you can administer it at home. Side effects, people can get local irritation side effects from the infusion. Headaches are kind of a class effect for all complement inhibitors that people can get when they're first starting. Usually it settles down. GI side effects like diarrhea and nausea are reported, but I haven't really seen them in my patients. I don't think they're super common. Okay. So in the last couple of drugs that we'll talk about are the factor inhibitors, and that's this over here, danicopan and iptacopan. So iptacopan is approved, but not yet funded. There's 2 studies. They're called the APPLY study and the APPOINT study. And so the APPLY study, the anti-C5 patients, in the APPLY study, patients that were on a C5 inhibitor were assigned to switch to iptacopan or to continue with the anti-C5 inhibitor. And in the APPOINT study, they looked at newly diagnosed patients that were not on inhibitors and started them on iptacopan. Whoops, sorry, that's the same slide. Okay, so this is the APPLY study at the top and the APPOINT study at the bottom. In the APPLY study, patients that switched had their hemoglobins go up fairly significantly. You can see that they got a pretty good response, actually. This is 120. And patients that continued on their anti-C5 therapy stayed around 90. And then in the APPOINT study, this is the newly diagnosed patients where they just were started on therapy, and you can see their hemoglobin come up over time. It took a little bit longer than those other studies, the C5 inhibitors, but they got a pretty good response. By the end of 2 years, they were up to 120, which is pretty normal. Okay. And then danicopan, again, is approved, have not yet funded. It's an oral medication 3 times a day. The way that this study was done, it was add-on therapy, so it wasn't given by itself. What they did was they took patients that were on eculizumab or ravulizumab for at least 6 months that still had low hemoglobins, extravascular hemolysis, and so their criteria was you still had to have a hemoglobin of less than 95 while on therapy, and a high retic count of greater than 120. and they randomized patients to a 2-to-1 to starting on the danicopan versus placebo. And so in this study, they're actually blocked at 2 points. You have C5 inhibition and you have factor D inhibition. And then at some point, they unblinded patients, and the patients on placebo could get the study drug. It did show that there was a difference between the two. And so you can see this is the change in hemoglobin. And in the danicopan group, the hemoglobin went up, and in the placebo group, it did not. The same thing down here. All right. All right. So that's it for, hang on, let me just go back for a second. Okay, so that's it for the therapies. I think I've covered. I didn't sort of have time to talk about anything that was in development, but all of these medications are sort of at the studied and approved, and some of them are funded, some of them are not quite funded yet. So you can see clearly a lot more options than we had a few years ago. So now for the last little part of my talk here, I've got sort of these other things that we want to think about with PNH treatment. And so they have to do with PNH complications. So we'll talk about a little bit about anticoagulation, ongoing follow-up, and then breakthrough hemolysis, which I alluded to a little bit before. And then there's some treatment-related issues because nothing is without side effects, even our best therapies. And so there is. So we'll talk about iron overload and meningococcal infections. So when it comes to thrombosis, the single most effective way to reduce the thrombosis risk in PNH is to start on complement inhibitor. It reduces the events from 7.5% down to 1% per patient year. It doesn't go down to zero. So your thrombosis risk is not nothing if you're started on complement inhibitor therapy, but it dramatically reduces it. And so for patients that were diagnosed and we start them on complement inhibitor before they've ever had a blood clot, there's no need to put them on a blood thinner. For patients that have a blood clot before they were started on complement inhibitor, say that was the reason, that was their presenting complaint, that was the reason they got diagnosed with PNH in the first place. It kind of depends on the clot. The guidelines, for the most part, say to continue because of the risk of further blood clots. But I have certainly in some patients with kind of what we would consider relatively minor clots, we have talked about stopping anticoagulation and just monitoring and the risk of that. Certainly in somebody with a very, very serious clot, such as a clot in the brain or a clot in the liver, my bias would be to continue the blood thinner for forever, basically. Patients that are on therapy and get a blood clot while they're on therapy clearly need to be on blood thinners and stay on blood thinners forever. The choice of anticoagulant, there's the most evidence for warfarin just because there's just the most experience with warfarin, but there's increasing comfort in using the newer anticoagulants as well, where you don't need this kind of monitoring back and forth. And so we have certainly done that as well. Okay, so end organ compromise. So in the complement inhibitor era, so I guess in the past 20 years, I think we're seeing a lot less of this. This mostly sort of applied when complement was activated unchecked and PNH was not treated. But we still monitor for some of these complications because, like I said, the treatment is not perfect and you may still have some ongoing hemolysis. And so here are a couple of things that can happen that we monitor for. So you can get pulmonary hypertension. Pulmonary hypertension results as a result of sort of this inflammation that goes on in your system with intravascular hemolysis. It scavenges nitric oxide, which is important in maintaining the pulmonary vasculature and keeping it open. You can get cardiovascular disease, partly because of the clot risk. You can get coronary disease for that. And so if anybody sort of has any cardiac symptoms, have a low threshold to do an echocardiogram or to do some imaging for that. Kidney disease. And again, depending on when you were diagnosed, the hemoglobin that's released from hemolysis is toxic to the kidneys. And then you can also get really tiny blood clots as well. So I often screen patients for proteinuria. So when you come in and do a urine test for me every year, that's what I'm looking for is a protein leaking into the urine. Okay, so breakthrough hemolysis. Um, so breakthrough hemolysis, by definition, is something that happens when patients are on therapy and they still get a hemolysis episode, and it can be sudden, and it can look like you were just diagnosed with PNH, even though you're on therapy now. Um, and so, what happens when you're on therapy is that your red blood cells that normally would have fallen apart stay intact, which is a good thing. Like we don't want them to fall apart. But when something happens to when something happens to sort of tickle your immune system and trigger that hemolysis, you have a huge number of red blood cells just kind of just waiting to fall apart. So that can be actually quite a serious event when it happens. Um, Things that can trigger it. So there's kind of two methods by which that occurs. So one is that potentially you've been undertreated or you missed a dose, or something happened with your infusion, you didn't get all of it, or something like that. If that's not the case, things that stimulate your complement system or your immune system can activate it. So an infection can do it. A vaccination can do it to, again, tickle your immune system. Surgical stress can do it. Pregnancy increases that activation as well. So people often need more during pregnancy. And like I mentioned, it can look like quite a catastrophic event. So I tell all my patients, if something happens, you get sick, you get jaundiced again, you get dark urine again, you have to call, you have to let us know. We have to, have a look at you and see what we can do. Treatment for breakthrough hemolysis. Like I said, it kind of depends on the cause. Obviously, if you missed a dose, then get your dose, and that usually fixes the problem. If it's some sort of infectious trigger, then we kind of know what caused it. The treatment depends on what drug you're on to begin with. And so if you're on eculizumab or ravulizumab, sometimes we can get a booster dose of that same medication. Crovalimab, the rescue is more crovalimab. There's a hypothetical risk of rescuing with an IV medication, so we wouldn't do that. For pegcetacoplan, we actually just increase the dose. So it's usually twice a week. We increase it to doing it. So if you have an event, you have a cold or a flu, or you're having surgery, do it three days in a row subcutaneously, or you can arrange for a IV infusion as well. If you're on a cofactor inhibitor, the rescue is a rescue dose of eculizumab or ravulizumab. If those therapies are not easily accessible or through logistics or funding or whatever, transfusion is always an option to just sort of get people through that breakthrough hemolysis episode. Okay, so two more to go. So infections. And so I mentioned at the very beginning that this is part of your innate immune system. The complement pathway is really important for fighting encapsulated bacteria like meningitis bacteria and pneumococcus bacteria. And as you probably know, meningitis is a very serious infection. And so all patients are required to be vaccinated when they're on these therapies, and you actually need a booster every 3 to 5 years. And so while the population gets 2 doses of meningococcus and they're good for life, patients that are on complement inhibitors need boosters every 3 to 5 years. Generally speaking, the vaccine itself can trigger complement. And so I often try to start people on therapy before we actually give the vaccination. And in that period of time where they're vulnerable, use some antibiotic prophylaxis to prevent infections while the vaccine is kind of kicking in. And then, of course, all patients are counseled to be vigilant for meningitis symptoms. If you have a high fever and a headache, get yourself to the emergency department. Tell them that you're on a complement inhibitor. You need antibiotics like right away. Okay, so I think this is my last complication, iron overload. So I mentioned previously that when you're on a C5 inhibitor, you get extravascular hemolysis, especially maybe after you've been on it for a while. And what happens is that the red cells that are recycled, you hang on to that iron, and that gets retained, and it gets retained often in the liver, and that can result in liver iron overload. Liver iron overload is dangerous. It can result in actual liver failure if we let it go long enough. It results in the organ not working properly. It's very stiff, and it doesn't do its usual function of clearing toxins from your system. The way this is treated is there's a couple of options. So now we have a bunch of proximal complement inhibitors, and switching drugs, like switching to a proximal inhibitor, is an option, or adding on danicopan in that scenario is an option. There's also iron chelation, and so iron chelation is used in various other disorders, MDS for patients a lot of transfusions, thalassemia, other blood disorders, and so there's medications that you take either orally or IV to try to get rid of that iron. Okay, so take-home messages from my talk. Hopefully I taught you something about PNH, what it is, how it's treated. It's a rare disease, sometimes with very serious symptoms or complications, and it's multi-system, so it's not always obvious, where it's coming from. It's not always obvious that it's a blood disorder. There's many new treatment options now, and there are more to come. And so now PNH patients, 20 years later, have many options for treatment. I will leave you with a couple of other resources in case you want to learn more about PNH. And so there's the PNH, the top one up here in the top left is the patient organization for PNH. It's the collective of patients that have PNH and their stories, resources that they find helpful. There's the Canadian PNH network, which is applicable to you guys and also to physicians that treat PNH, kind of next to it there. We do have there is a registry that's international. I don't believe that we're not open yet at Sunnybrook. We're still working on it, but there's an international registry because it's a rare disease. They want to sort of gather experiences from across the world. And I put Sunnybrook up there because, as Sydney mentioned in my introduction, I also lead the Sunnybrook Hematology Biobank, and we have a number of patients with PNH that have volunteered to donate their blood for future research. So lots of directions going on there. Okay, any questions?
Thank you so much. So you mentioned that patients with MDS or aplastic anemia, they often have small clones. Do you ever see large clones in these patient populations?
Not so. You can see sometimes the clone changes, and so certainly there have been a number of cases where they have aplastic anemia. They start off with a small clone, they get treated for the aplastic anemia, and then suddenly that clone becomes from 1%, it becomes 10%, and then 30%, and then they have PNH and they need treatment for their PNH. So certainly that happens. I tend to sort of see them switching over as opposed to having them concurrently. Although, I mean, as I say that, I can think of one-off case where both have happened at the same time, where they have a large PNH clone as well as MDS and kind of progressing to acute leukemia. So never say never.
Right, because I was wondering, with monitoring for extravascular hemolysis, if the patient has concurrent MDS or AA, then they're not producing reticks. So how do you monitor for EVH in that context? Would it just be low hemoglobin or extra fatigue despite being on a treatment?
Yeah. So excellent question. There's a couple of things. So I think one, you're right, that they don't have that reticulocyte response, but you would see persistent anemia. You might see elevated bilirubin. And actually, the flow cytometry test can actually look for those fragments of C3 that are deposited. So we weren't doing that routinely before. We are now at Sunnybrook. And so seeing the C3d deposition on those red blood cells kind of sort of it increases your risk for extravascular hemolysis. So you'd be more suspicious. Yeah.
Thank you.
Yeah, no problem.